Welcome, everyone. I'm Dr. Dawn Shepard, and I want to begin by acknowledging something that brings all of us to this table. Most healthcare providers, including nurses with years of experience, will tell you that their formal education on Parkinson's disease was limited, outdated, or simply non-existent. Closing that gap is why we are here. This session spans the full continuum of Parkinson's disease, from the earliest prodromal symptoms that may predate motor signs by years, through the complexities of mid-stage management, all the way to advanced stage and end-of-life care. We are going to cover clinical diagnosis, assessment tools, pharmacology, rehabilitation, hospital safety, caregiver support, and surgical therapies. Before we get into clinical specifics, let's ground ourselves in where Parkinson's disease comes from, how we think about it today, and why the stakes are as high as they are. Understanding the history and scale of this disease shapes how we communicate with patients and families, and how urgently we approach our own education. These four objectives are the navigational framework for everything that follows. Notice that they progress from knowledge, describing what Parkinson's looks like, through application, outlining how we manage it, to recognition and synthesis, identifying caregiver strain, hospital risks, and the nursing role across the disease continuum. I want to draw your attention to that fourth objective in particular, identifying multidisciplinary nursing opportunities. Nurses at all levels are medication managers, symptom educators, safety advocates, caregiver supporters, and system change agents. James Parkinson described what he called the shaking palsy in 1817, a 6-patient essay that remains one of the most precise clinical descriptions in neurological history. He documented the resting tremor, the festinating gait, the progressive nature, and even the impact on daily function, all without the benefit of a microscope, neuroimaging, or a single laboratory test. It would be another 50 years before Jean-Martin Charcot added rigidity to the clinical picture and renamed the condition in Parkinson's honor. The 1960s represent a turning point that still anchors everything we do today. The discovery that the substantia nigra was depleted of dopamine and that levodopa could replenish it transformed Parkinson's from a slowly progressing disability into a treatable condition. The first paper on levodopa therapy changed the trajectory of millions of lives. It also introduced the complexity we still navigate. Levodopa is not disease-modifying, and over time, its therapeutic window narrows. The early 2000s brought another revolution. Alpha-synuclein was identified as the protein that misfolds and aggregates into the Lewy bodies that are Parkinson's pathological signature. The first genetic cause of PD was confirmed, and critically, we began to understand that this pathology likely starts not in the substantia nigra, but in the lower brainstem and the enteric nervous system, which explains why constipation, hyposmia, and REM sleep behavior disorder can precede motor symptoms by a decade or more. Today's research is chasing biomarkers in skin, cerebrospinal fluid, and blood to catch Parkinson's before the motor symptoms ever appear. Approximately 1 million Americans are currently living with Parkinson's disease, and that number is expected to double by 2040 as the population ages. Parkinson's is now the fastest-growing neurological disorder in the world by prevalence. The Michael J. Fox Foundation has contributed approximately $2.5 billion to research, and the Parkinson's Foundation runs PD Generation, a free genetic testing program, because the stakes are that high. The 10-plus body systems statistic is perhaps the most important one for our clinical framing. We tend to think of Parkinson's as a movement disorder, but movement is just the visible tip of the iceberg. The non-motor symptoms, depression, anxiety, cognitive decline, constipation, orthostatic hypotension, sleep disorders, hyposmia, pain, fatigue, are often more disabling than the tremor, and they are frequently underreported because patients either don't recognize them as Parkinson's symptoms or they don't want to burden their care team. One study of nursing home residents with Parkinson's found an average of 13 non-motor symptoms per resident. 13. The economic burden of $52 billion annually reflects not just the direct costs of medication and hospitalizations, but the indirect costs of lost productivity, caregiver time, and premature institutionalization. The substantia nigra is a small pigmented region in the midbrain. In a healthy brain, it produces dopamine and releases it into the striatum, where it facilitates smooth, coordinated movement through the basal ganglia circuit. In Parkinson's disease, the dopaminergic neurons in the substantia nigra progressively die. By the time motor symptoms are clinically apparent, meaning by the time a patient walks into a clinic with a tremor, approximately 60 to 80% of those neurons are already gone. That is the nature of the disease's insidiousness. The protein at the center of this pathology is alpha-synuclein. In Parkinson's, it misfolds, aggregates, and forms toxic clumps called Lewy bodies within neurons. Research now suggests this pathology can spread from cell to cell in a prion-like manner, which explains both the disease's progression and its multi-system involvement. The Brock staging hypothesis proposes that the pathology begins in the olfactory bulb and lower brainstem, which is why loss of smell and constipation are early signs and then ascends through the brain over years and decades. Understanding this helps us explain the disease to patients in a way that makes sense to them. Now we move from the biological substrate to the clinical surface. What Parkinson's looks like when a person walks into your clinic or your hospital room. The moment a patient enters the room, you are already gathering data. How are they moving? How is their facial expression? Are they blinking? Is their arm swinging? Is their voice soft? These observations, before a hand is ever laid on a patient, are often the most revealing. Bradykinesia, slowness of movement, is the required core feature for a clinical diagnosis of Parkinson's disease. It is not optional. You can have a patient with significant tremor and rigidity, but if bradykinesia is not present, you should question the diagnosis. Bradykinesia manifests clinically as decrement. When you ask a patient to rapidly tap their fingers or alternate their hands, the amplitude and speed fade progressively. It is not just slow movement, it is movement that gets smaller and slower as it continues. The classic resting tremor, often described as pill rolling because it looks like rolling a small tablet between thumb and forefinger, is present in about 70% of patients at diagnosis, but it is not universal. Tremor that disappears with intentional movement and returns at rest is highly suggestive of Parkinson's. Rigidity can be cogwheel, a ratcheting quality, or lead pipe, a sustained resistance throughout the range of motion. Postural instability typically appears later. Its early presence should raise concern for an atypical syndrome, like progressive supranuclear palsy. Now look at the non-motor column. Early symptoms can precede motor symptoms by a decade. Sleep behavior disorder is particularly important. It is present in up to 80% of people who will go on to develop a synucleinopathy, and acting out dreams, sometimes violently, is often the spouse's complaint long before a tremor is noticed. The non-motor burden frequently drives quality of life more than the visible motor symptoms, and it is frequently underreported. Ask directly and ask often. Before the patient even sits down, watch them walk from the waiting room. Watch them get out of the chair. Look at facial expression. Hypomimia, or masked face, is a classic Parkinson's sign and is often what makes people seem depressed even when they are not. Count their blink rate. Listen to their voice. These are free data points that disappear if you wait for the formal exam. For motor testing, rapid repetitive movements, finger tapping, hand opening and closing, foot tapping, assess bradykinesia. Ask the patient to do these as fast and as big as possible, and watch for the decrement in amplitude and speed that is the hallmark finding. For rigidity, passively move the wrist, elbow, and neck without asking the patient to assist. You are feeling for that increased resistance. The pull test assesses postural reflexes. Stand behind the patient, warn them, and give a firm backward pull at the shoulders. A patient who needs more than one step to recover, or who would fall without your catch, has abnormal postural reflexes. The critical clinical distinction every nurse and clinician must understand is that Parkinsonism is a syndrome. It is a collection of symptoms, and Parkinson's disease is its most common cause, but not the only one. Atypical Parkinsonism syndromes like progressive supranuclear palsy, multiple system atrophy, and corticobasal syndrome can look like Parkinson's disease early in their course, but respond poorly or not at all to levodopa, progress faster, and have earlier falls and autonomic failure. Cognitive screening is not optional in Parkinson's care. It is essential infrastructure. The Montreal Cognitive Assessment is the preferred tool over the mini mental state exam because it is more sensitive to the executive function and visuospatial deficits that characterize Parkinson's-related cognitive impairment. A score of 26 or above is generally considered normal. 18 to 25 suggests mild impairment. Below 18 indicates moderate to severe deficits. But the number alone is not the whole story. What matters is the trajectory. A patient who scores 27 at one visit and 24 18 months later has lost ground is clinically significant even though both scores look acceptable. Psychiatric screening must cover mood, anxiety, apathy, sleep, hallucinations, and impulse control. And these conversations need to happen with the patient alone and then with the caregiver separately. Why separately? Because the stories are often different. A patient may deny hallucinations in front of a spouse, who then tells you the patient has been talking to people who aren't there for months. A caregiver may minimize their own burden in front of the patient. Getting both perspectives is not optional. One of the most clinically important distinctions to internalize is the difference between Parkinson's disease dementia and dementia with Lewy bodies. The timing of cognitive symptoms relative to motor symptoms is what separates them. If a patient has established Parkinson's disease for at least a year before cognitive decline reaches the level of major neurocognitive disorder, the diagnosis is Parkinson's disease dementia. If cognitive decline occurs before or within 12 months of the motor symptoms, Lewy body dementia is the more appropriate diagnosis. This distinction has treatment implications, and it matters for how we counsel families about prognosis and medication choices, particularly because both conditions carry severe sensitivity to neuroleptic medications. The DSM-5 replaced the older category of dementia with the broader term major neurocognitive disorder and introduced the companion category of mild neurocognitive disorder to capture clinically meaningful cognitive decline that has not yet reached the threshold of independence impairment. This framework is directly applicable to Parkinson's, where cognitive changes are common and exist on a spectrum. Understanding these criteria lets us communicate precisely with physicians, document accurately in the medical record, and set appropriate expectations with patients and families. Criterion A requires evidence of decline from a prior level in at least one of 6 cognitive domains: complex attention, executive function, learning and memory, language, perceptual motor function, and social cognition. The key phrase is from a prior level. The decline must represent a change, not a lifelong baseline. This is established through 2 complementary pieces of evidence. First, concern from the patient, an informant, or the clinician, and second, objective performance on standardized testing. Major neurocognitive disorder typically corresponds to performance 2 or more standard deviations below appropriate norms, at or below the 3rd percentile. Mild neurocognitive disorder typically falls in the 1 to 2 standard deviation range, between the 3rd and 16th percentile. Criterion B is where the major/mild distinction becomes functionally meaningful. In major neurocognitive disorder, the cognitive deficits interfere with independence in daily activities. The minimum threshold is that the person requires assistance with complex instrumental activities, paying bills, managing medications, handling finances. In mild neurocognitive disorder, independence is preserved, but tasks require more effort, more time, or compensatory strategies. The patient might still pay the bills, but now keeps an elaborate checklist to do it, whereas before it was automatic. That shift is clinically real and warrants clinical attention even if the patient insists they are fine. For Parkinson's specifically, the diagnosis of neurocognitive disorder due to Parkinson's disease requires that the disorder occur in the setting of established Parkinson's disease with insidious onset and gradual progression. The cognitive profile of Parkinson's disease is distinctive and differs meaningfully from Alzheimer's disease. Whereas Alzheimer's leads with episodic memory loss, the patient forgets conversations, misplaces items, repeats themselves. Parkinson's-related cognitive impairment leads with executive dysfunction and slowed processing speed. These patients have trouble initiating tasks, switching between them, holding information in working memory, and filtering irrelevant stimuli. They can often retrieve memories when given cues. Their problem is accessing the information, not storing it. This distinction matters for diagnosis and for counseling. Complex attention impairment shows up in daily life as difficulty multitasking, easy distractibility, and the inability to process competing stimuli. A patient might manage fine in a quiet room but become overwhelmed in a noisy environment. Executive dysfunction manifests as difficulty planning a multi-step task, cooking a meal, managing a complex medication regimen, navigating an unfamiliar environment. Perceptual motor deficits include trouble judging distances, navigating in dim lighting, difficulty with parking, and the visuospatial component of handwriting deterioration. There is a critical assessment principle that applies here. When you are testing cognition in a patient with Parkinson's, you must use assessments that do not penalize motor slowing. Timed tasks that require fine motor movements will underrepresent cognitive ability and overrepresent motor impairment. Use verbal or oral response tasks wherever possible to isolate cognition from the motor component of the disease. These 4 scales are the clinical language of Parkinson's disease management. You will see them referenced in consult notes, research papers, deep brain stimulation candidacy criteria, and Medicare documentation requirements. The Movement Disorder Society Unified Parkinson's Disease Rating Scale is the gold standard for comprehensive disease assessment. Part 1 captures non-motor experiences of daily living, including depression, anxiety, sleep, cognition, and urinary symptoms. Part 2 covers motor experiences of daily living as reported by the patient, things like speech, saliva control, handwriting, dressing, and walking. Part 3 is the neurologist's motor examination, the objective assessment of speech, facial expression, tremor, rigidity, bradykinesia, gait, and postural stability. A Part 3 score above 32 is generally considered moderate to severe motor impairment. Part 4 addresses motor complications, wearing off, dyskinesia, and painful off periods. The Unified Parkinson's Disease Rating Scale is also central to deep brain stimulation candidacy. Medicare and the FDA require documented improvement of at least 30% on Part 3 between the off and on medication states before surgery can be approved. The Hoehn and Yahr scale is older and simpler, but it remains useful for rapid staging and for communicating with patients and families about where they are in the disease trajectory. Stages 1 and 2 are early, typically without balance impairment. Stage 3 introduces postural instability, but the patient remains independent. Stages 4 and 5 represent significant dependence and loss of mobility. The Montreal Cognitive Assessment is our primary cognitive screen, more sensitive than the mini mental state exam for the executive and visuospatial deficits that characterize Parkinson's. And the Parkinson's Disease Questionnaire, with its 39-item quality of life measure across 8 domains, captures what the Unified Parkinson's Disease Rating Scale misses: how the disease actually feels to live with. The brain MRI cannot diagnose Parkinson's disease. The substantia nigra atrophy of Parkinson's is too subtle for conventional imaging to reliably detect. What MRI does do is rule out other explanations for Parkinsonism to vascular disease, structural lesions, normal pressure hydrocephalus, and tumors. It is a diagnostic exclusion tool, not a confirmation tool. The DAT scan, a SPECT imaging study using a radio-labeled dopamine transporter ligand, is a meaningful adjunct. It demonstrates reduced striatal dopamine transporter uptake in Parkinson's disease and Lewy body dementia, and it is most useful when the clinical picture is unclear. For instance, when distinguishing idiopathic Parkinson's from essential tremor or drug-induced Parkinsonism. However, DAT scan cannot distinguish between Parkinson's disease and other synucleinopathies like multiple system atrophy or progressive supranuclear palsy. The Levodopa Challenge Test, assessing motor function before and after a supervised levodopa dose, remains the most practically important diagnostic test. A 30% or greater improvement in Part 3 Unified Parkinson's Disease Rating Scale score strongly supports idiopathic Parkinson's and is required for deep brain stimulation candidacy. The emerging biomarker space is moving rapidly. The alpha-synuclein seed amplification assay, performed on CSF or skin biopsy, detects misfolded alpha-synuclein with high sensitivity and specificity and may become a cornerstone of preclinical diagnosis. Olfactory testing with the UpSite or University of Pennsylvania smell identification test is inexpensive and clinically informative. Hyposmia is present in approximately 90% of idiopathic Parkinson's patients, so normal olfaction should prompt reconsideration of the diagnosis. Neurofilament light chain, measured in blood, is elevated in atypical Parkinsonism and can help differentiate multiple system atrophy and progressive supranuclear palsy from idiopathic PD, important when the clinical picture is ambiguous. Genetic testing should be considered in anyone with early onset disease before age 50, a strong family history, or atypical features. Parkinson's disease is a diagnosis of exclusion, meaning we arrive at it when the clinical features are present and other explanations have been ruled out. The most important distinguishing features of idiopathic Parkinson's are asymmetric onset, resting tremor, and a meaningful response to levodopa. That last point cannot be overstated. If a patient has features consistent with Parkinsonism but does not respond meaningfully to an adequate levodopa trial, we need to reconsider the diagnosis. Poor levodopa response is the cardinal red flag for an atypical syndrome. Progressive supranuclear palsy is the most common atypical Parkinsonism. The signature features are falls in the first year of illness, often backward falls, and supranuclear vertical gaze palsy, which means the patient cannot voluntarily look downward even though the eyes move normally in response to passive head movement. The hummingbird sign on sagittal MRI, reflecting midbrain atrophy, is a helpful radiological clue. Multiple system atrophy presents with a combination of Parkinsonism, cerebellar ataxia, and prominent autonomic failure, orthostatic hypotension, urinary incontinence, and sometimes inspiratory stridor. The hot cross bun sign on axial MRI of the pons is characteristic. Both progressive supranuclear palsy and multiple system atrophy have much more rapid progression than idiopathic PD and a shorter survival. The Lewy body dementia and Parkinson's disease dementia distinction is one of the most practically important for nursing because of medication safety. Both involve Lewy body pathology, both involve Parkinsonism and cognitive decline, and both carry severe sensitivity to antipsychotic medications, specifically typical antipsychotics, but also many atypicals. A patient with Lewy body dementia who receives haloperidol can experience a catastrophic, potentially fatal, neuroleptic sensitivity reaction with acute rigidity, confusion, and autonomic instability. As a reminder, if Parkinson's disease was established at least 1 year before dementia reached major neurocognitive disorder severity, the diagnosis is Parkinson's disease dementia. If dementia came first or within that 12-month window, Lewy body dementia is the appropriate diagnosis. This distinction should be clearly documented in every patient's chart. We now move into the territory where nursing knowledge most directly prevents harm. Medication management in Parkinson's disease is precise and time-sensitive. No other aspect of Parkinson's nursing care has a more immediate and measurable impact. The foundational principle of Parkinson's pharmacotherapy is one that we must be honest with patients about from the very first visit. No current medication for Parkinson's disease modifies the underlying disease process. Every medication we use is symptomatic. We are managing what the patient experiences, but we are not slowing the death of dopaminergic neurons or the spread of alpha-synuclein pathology. Treatment is initiated when symptoms interfere with function or quality of life. This sounds straightforward, but in practice it is nuanced. A patient who is a professional violinist may find that a very subtle tremor in the right hand is already disabling to their work. A retired person with a modest resting tremor may have no functional impairment and prefer to defer medication. The same symptom severity can mean entirely different things to different people. Setting realistic expectations is one of the most therapeutic things a nurse can do in a Parkinson's clinic. Levodopa will improve tremor and slowness significantly. It may help stiffness and gait, but it is unlikely to resolve balance problems and freezing of gait. These symptoms are often caused by non-dopaminergic pathways that levodopa cannot address. Clarifying which symptoms are and are not levodopa responsive prevents unnecessary dose escalation, manages expectations, and maintains trust. Constipation significantly impairs levodopa absorption, so addressing it is not comfort care, it is pharmacokinetic optimization. Carbidopa-levodopa is the cornerstone of Parkinson's pharmacotherapy and the most effective medication we have for motor symptoms. Levodopa is converted to dopamine in the brain. Carbidopa prevents that conversion from happening peripherally, which reduces nausea and allows more levodopa to cross the blood-brain barrier. When a patient develops nausea on carbidopa-levodopa, adding extra carbidopa as a separate tablet is more effective than adding an antiemetic because the antiemetic may itself be a dopamine blocker. The practical meal timing tip matters enormously. Protein and fatty meals significantly delay and reduce levodopa absorption. The working clinical guidance is to take the medication and then eat approximately 30 minutes later when possible. For patients who cannot tolerate taking medication on an empty stomach, a small, non-protein snack is acceptable. Understanding the difference between immediate release and extended release formulations is critical for nursing practice, particularly in hospital settings where formulary substitutions can cause serious harm. Immediate release carbidopa-levodopa peaks at about 1 hour and has a meaningful duration of 3 to 5 hours. Extended release formulations peak more slowly, about 1 to 2 hours, and last up to 6 hours, but with a gradual tail off. When a patient is admitted to the hospital with a home medication, you cannot assume which formulation, you must verify. And COMT inhibitors extend levodopa effect by preventing its peripheral breakdown, and tacopone is taken with each levodopa dose, while the once-daily opicapone offers convenience. Both can cause harmless orange-brown urine discoloration, which patients should be warned about. The dopamine agonist risks column deserves extended discussion at every patient encounter. Impulse control disorders, gambling, hypersexuality, compulsive eating, compulsive shopping, and a behavior called punding, which is purposeless repetitive activity, can develop or worsen on dopamine agonists. The mechanism is overstimulation of the mesolimbic reward pathways. These behaviors are often underreported because patients are embarrassed, families don't connect them to the medication, and clinicians don't ask. Screen for impulse control disorders at every visit for every patient on a dopamine agonist and obtain collateral history from a family member. Motor fluctuations are one of the most challenging aspects of mid to advanced stage Parkinson's management, and understanding them is essential for any nurse working with this population. In the early years of Parkinson's therapy, levodopa provides relatively smooth, consistent benefit. The therapeutic window is wide, and dosing every 4 to 6 hours is sufficient. But as the disease progresses and dopaminergic neurons continue to be lost, the brain becomes increasingly dependent on the immediate availability of exogenous levodopa. The therapeutic window narrows, and patients begin to experience wearing off, a return of symptoms before the next dose is due. Wearing off can be subtle at first. A patient might notice that their tremor returns an hour before their next scheduled dose. Over time, this can escalate to unpredictable off periods, sudden dramatic losses of motor function that can occur even when medication timing appears adequate. Dyskinesias, the involuntary, often writhing or flowing movements, are a different problem. They typically represent peak dose dopamine excess, occurring about an hour after a dose when brain dopamine levels are highest. The management principles follow from this: dose splitting, reducing the amount of each individual dose while increasing frequency, can flatten the peak and reduce dyskinesia without losing overall efficacy. Amantadine and its extended-release formulation, Gocovri, are the primary pharmacological tools for dyskinesia. The Motor Diary, available through the Parkinson's Foundation in 30-minute increment format, is an invaluable clinical tool. It captures the pattern of on, off, and dyskinesia times across the day and allows the clinician to precisely identify where the schedule needs adjustment. For acute, unpredictable off episodes that cannot be managed by dose adjustment alone, subcutaneous apomorphine injection, Apokin, provides rescue relief within minutes and is the only FDA-approved on-demand treatment for off episodes, functioning much like an insulin rescue pen and important to know about for patients with severe motor fluctuations. Psychosis in Parkinson's disease is a medical emergency that demands a systematic, stepwise approach, and the first step is always to rule out non-Parkinson's causes. A patient presenting with new or worsened hallucinations or delusions should be evaluated for infection, especially urinary tract infection, which is common and notoriously underrecognized in older adults. Recent illness, medication changes, dehydration, metabolic disturbances, and hospital admission are all precipitants. Even in a patient with established Parkinson's disease, never assume that the psychosis is simply the disease progressing without first excluding a treatable medical cause. The medication deprescribing ladder is the next step. The medications most likely to provoke or worsen psychosis in Parkinson's are, in roughly descending order, anticholinergics, dopamine agonists, MAOB inhibitors, amantadine, and levodopa itself. The goal is to reduce the total dopaminergic burden by eliminating or reducing the agents least essential for motor function before touching levodopa. This requires careful clinical judgment because reducing dopaminergic medications will worsen motor function. The art is finding the balance point where psychosis is controlled without unacceptable motor deterioration. When pharmacological treatment is needed, the rules are unambiguous. Typical antipsychotics, haloperidol, prochlorperazine, and their relatives, are contraindicated in Parkinson's disease. They block dopamine receptors and will dramatically worsen motor symptoms and can precipitate a neuroleptic malignant-like syndrome. The safe options are thiopine at low doses, clozapine, which requires CBC monitoring for granulocytosis and sometimes has access barriers, and pimavanserin, a serotonin inverse agonist specifically approved for Parkinson's disease psychosis. Thiopine is widely used in practice due to its tolerability and familiarity, but the evidence base specifically for Parkinson's disease psychosis is limited. Pimavanserin remains the only FDA-approved agent for this indication and has the strongest evidence base. Pimavanserin has a delayed onset of 3 to 6 weeks and carries a black box warning regarding mortality in elderly patients with dementia-related psychosis. Educating patients and caregivers that hallucinations in Parkinson's are often non-threatening at first, so it is important to note onset and the character of intensity. If there is one evidence-based intervention in Parkinson's disease that may do more than just manage symptoms, that may actually slow disease progression, it is exercise. Multiple meta-analyses now demonstrate that Parkinson-specific exercise combined with medication outperforms medication alone for both motor and non-motor outcomes. We are not just talking about feeling better. We are talking about measurable improvements in Unified Parkinson's Disease Rating Scale scores, Berg balance, gait speed, and cognitive function. Exercise is not an optional lifestyle add-on in Parkinson's care. It is a clinical intervention with a dose-response relationship, and it should be prescribed with the same intentionality as a medication. Voice changes affect up to 90% of people with Parkinson's disease over the course of the illness, making this the most prevalent symptom that most people don't think of first. The characteristic change is reduced vocal intensity. The voice becomes soft, monotone, and often breathy. What makes this particularly challenging is that patients are often unaware of how soft their voice has become. The brain's perceptual system, the same system responsible for calibrating how loud we are speaking, is disrupted by the disease, so patients genuinely believe they are speaking at a normal volume when they are not. This is not denial or lack of effort. It is a neurological perceptual deficit. LSVT loud, or Lee Silverman voice treatment, is the gold standard intervention. It is intensive by design, 4 sessions per week for 4 weeks, focused on a single target, increasing vocal loudness with the phrase, think loud. The intensity is deliberate. The research shows that the intensive protocol produces acoustic improvements, better speech intelligibility, and longer phonation time that are maintained at 6 months, whereas less intensive NHS-style protocols at 1 session per week produce no significant benefit compared to no treatment. Speak Out is a comparable alternative protocol with cognitive exercise integration, 3 sessions weekly for 6 weeks, with maintenance through the Loud Crowd group format. Both programs are evidence-based and both address the same core problem through slightly different mechanisms. On the physical therapy side, evidence is clear that high-intensity exercise, targeting 80 to 85% of maximum heart rate, produces superior motor outcomes compared to moderate intensity and is associated with slower unified Parkinson's disease rating scale progression over time. The clinical target for perceived exertion is 6 to 8 on a 10-point scale. This is not comfortable exercise, it is challenging exercise. And that intensity is what produces the neuroplasticity benefit. For patients on beta blockers or with pacemakers, heart rate targets are unreliable. Use perceived exertion instead. LSVT Big, the movement counterpart to LSVT Loud, uses the same intensive 4 days per week structure, but focuses on large amplitude, high-velocity movements to recalibrate the brain's sense of normal movement size and translate into improved gait speed, balance, and arm swing. Freezing of gait is one of the most frightening and dangerous symptoms in Parkinson's disease, and one of the least responsive to dopaminergic medication. It is an involuntary, usually brief cessation of stepping that can occur at doorways, in narrow spaces when approaching a destination, at turns, and under dual task conditions. A patient who walks smoothly in an open hallway may freeze completely when approaching a doorway or stepping into an elevator. The mechanism involves basal ganglia cortical circuit dysfunction that is not well addressed by levodopa, which is why it tends to worsen in later stages despite medication optimization. The cueing strategies we teach patients and caregivers are practical, effective, and need to become instinctive. Auditory rhythm, a metronome, music, or the clinician counting 1, 2, 3 can interrupt the freeze by engaging alternative motor pathways. Shifting weight from side to side, focusing on taking one deliberate big step, or imagining stepping over a line on the floor can all initiate movement. Some patients respond to visual cues, stripes of tape on the floor, laser lines projected by walking aids. The physiotherapy literature supports hands-on facilitation, sometimes described as the big dance, where the therapist gently rocks the patient's pelvis to initiate weight shift and stepping. Caregivers can be trained to do this and should be. Home safety is a systemic nursing priority. The assessment should cover every space the patient uses: doorway widths, bathroom accessibility, lighting levels especially at night, carpet edges, furniture arrangement in relation to walking paths, and the bedroom setup for nighttime navigation. Bed rail selection requires clinical judgment. Standard rails are simplest, but telescoping models that mount to the bed frame may be safer when falls risk is high. Walking poles deserve mention as an alternative to rollators that many patients find more acceptable. They do not look like a disability aid, they promote upright posture and arm swing, and they work well in tight spaces and on outdoor terrain. Walker and rollator selection should consider wheel size. Larger wheels handle uneven surfaces and transitions better, as well as weight, foldability for car transport, and caregiver feasibility for folding and lifting. Advanced therapies represent a significant and growing part of Parkinson's care, and nurses are frequently the first point of contact when patients and families raise questions about them. Being able to explain what deep brain stimulation is and is not, who is and is not a candidate, and what the realistic outcomes look like is a core nursing competency in any Parkinson's center. The most important thing you can convey: deep brain stimulation is not a cure. It is a powerful tool for specific symptoms in carefully selected patients, and it requires lifelong programming, follow-up, and adjustment. Deep brain stimulation candidacy begins long before the neurosurgeon is involved. The workup is multidisciplinary and sequential. A movement disorder specialist confirms idiopathic Parkinson's disease and identifies potential candidates. Brain MRI rules out structural abnormalities. Formal neuropsychological testing screens for dementia because cognitive impairment is a contraindication and surgery can worsen it. And the Levodopa challenge test documents at least 30% improvement in Unified Parkinson's Disease Rating Scale. Part 3, from the off to the on medication state. This last criterion is essential. Deep brain stimulation for motor symptoms largely mirrors what levodopa can do, so if levodopa does not help significantly, deep brain stimulation will not either, with the important exception of tremor, which can respond to deep brain stimulation even when levodopa responsiveness is limited. The subthalamic nucleus versus globus pallidus internus target decision is one of the most frequently misunderstood aspects of deep brain stimulation, and it matters for nursing education because patients and families will ask about it. Both targets address tremor, rigidity, bradykinesia, and motor fluctuations. The subthalamic nucleus often allows for greater medication reduction postoperatively, which can reduce dyskinesia and medication burden. The globus pallidus internus is often preferred when dyskinesia is particularly prominent, when cognitive concerns are present, or when mood stability is a priority, because subthalamic nucleus stimulation has been associated with mood effects in some patients, including increased impulsivity. The decision is made by a multidisciplinary team through deliberate review of the individual patient's clinical profile. It should never feel like a random choice. Modern deep brain stimulation technology has advanced significantly. Directional leads allow stimulation to be steered away from structures that cause side effects, like the internal capsule, which causes muscle contractions, or the medial lemniscus, which causes paresthesias, and toward the therapeutic target. Adaptive deep brain stimulation, recently FDA approved through the ADAPT-PD trial, uses local field potential signals from the brain, specifically beta frequency oscillations around 20 Hz that correlate with motor symptom severity, to automatically adjust stimulation in real time. This closed-loop approach reduces overstimulation during sleep and sleep when symptoms are minimal, and increases stimulation in response to symptom worsening. Approximately 90% of ADAPT-PD participants preferred continuing adaptive deep brain stimulation after experiencing it. Remote programming via secure internet connection now allows clinicians to adjust settings during video visits, dramatically improving access for patients in rural areas. Not every patient who needs more than oral medications is a deep brain stimulation candidate, and not every patient who is eligible wants brain surgery. Knowing the alternatives broadens the therapeutic toolkit and allows for more nuanced, shared decision-making. The two main alternatives to deep brain stimulation are continuous infusion therapies and ablative procedures. Continuous infusion options deliver dopaminergic medication without the peaks and troughs of oral dosing. Levodopa-carbidopa intestinal gel is delivered directly into the jejunum via a percutaneous tube, providing continuous, steady dopamine replacement. Subcutaneous apomorphine infusion delivers a dopamine agonist continuously under the skin. Both are used when oral regimens are no longer adequate, when off time is severe, unpredictable, or unresponsive to oral adjustments, and both require significant patient and caregiver commitment for device management. Focused ultrasound is an incisionless ablative procedure. MRI-guided ultrasound waves are focused to create a precisely targeted thermal lesion, essentially a controlled microscopic stroke, in the thalamus for tremor control. Patients are awake and can see their tremor disappear in real time during the procedure. It is FDA approved for essential tremor and tremor-dominant Parkinson's disease. The limitations are important. It addresses tremor only, not rigidity, bradykinesia, or fluctuations. Long-term data beyond 5 years is limited. Bilateral application in Parkinson's disease remains investigational, with unilateral treatment. The current standard of care for PD due to risks of speech and balance complications with bilateral lesioning, and the resulting lesion can be misidentified as a stroke on future imaging if the radiologist is not informed, potentially leading to unnecessary workup and incorrect management. Always document that a patient has had focused ultrasound in their medical record. Hospital safety is where Parkinson's nursing advocacy has the most immediate, measurable impact. Patients with Parkinson's disease experience a 44% higher risk-adjusted complication rate during hospitalizations compared to patients without Parkinson's. 75% of people with Parkinson's who are hospitalized experience complications. 61% of those complications are attributable to staff not understanding the importance of medication timing. Let me describe what happens when Parkinson's medication timing fails in the hospital. A patient was admitted for a procedure in the emergency department, and then on the inpatient floor, their medication was not administered for 11 hours. By the time the team recognized the problem, the patient was rigid, unable to speak clearly, drooling, febrile, short of breath, and delirious. The clinical picture resembled neuroleptic malignant syndrome. And then, because the delirium was attributed to altered mental status without recognizing its cause, the patient was given haloperidol twice. Haloperidol, which is a dopamine blocker in a patient with Parkinson's disease, who was already in crisis because of dopamine deprivation. This is a case from a nationally recognized movement disorder program, described as a teaching example precisely because it represents a pattern of failure, not an isolated incident. The 15-minute window is the clinical standard at centers with Parkinson's safety programs. Carbidopa-levodopa must be administered within approximately 15 minutes of the patient's home schedule, not the standard floor administration time. Not 4 times a day, evenly distributed across 24 hours. The patient's personal home schedule, which has been optimized over months or years to align with their wake-sleep cycle, meal timing, and activity demands. When a patient is admitted, the first nursing action should be medication reconciliation that captures the exact home schedule and flags every PD medication as time critical. The Parkinson's Foundation Hospital Safety Booklet is a practical resource that patients can carry with them and present on admission. The medications to avoid list is non-negotiable and applies across all care settings. Haloperidol and other first-generation antipsychotics, prochlorperazine, used for nausea, and metoclopramide, used for GI motility and nausea, are all dopamine receptor blockers. Giving any of them to a patient with Parkinson's disease can cause severe acute worsening of motor symptoms, rigidity, inability to swallow, respiratory compromise, and can precipitate a crisis that extends the hospital stay dramatically. Bubble-packed medications in original pharmacy packaging are one practical solution. They allow patients to bring their medications from home in a format that hospitals can accept and verify. Crushable formulations should be identified in advance for patients with swallowing difficulty. The research on mobility in hospitalized Parkinson's patients is unambiguous and clinically actionable. A study comparing 300 hospitalized patients with Parkinson's disease to 12,000 patients without found that Parkinson's patients who were mobilized at least one day during their hospitalization had significantly shorter lengths of stay and were substantially more likely to be discharged home rather than to a facility. The benefit of mobility was greater for patients with Parkinson's than for any other patient group in the study. This is not a gentle nudge toward comfort care. This is strong clinical evidence that mobilization is a medical intervention with discharge outcome implications. The clinical reality in many hospitals is the opposite of what the evidence recommends. Patients with Parkinson's are often perceived as fall risks and managed with bed rest, side rails up, and call light within reach. This approach feels safe but is clinically counterproductive. Immobility accelerates deconditioning far faster in Parkinson's patients than in patients without the disease, because the disease already impairs the automatic postural and writing reflexes that help people recover from wobbles and stumbles. The Move Heal program at Cleveland Clinic spans multiple hospitals and provides a model for embedding Parkinson's-specific early mobilization into hospital culture. Every nurse on every shift assesses mobility and facilitates safe activity. Fall risk assessment in Parkinson's is daily and shift-specific, not admission-based. A patient who ambulates safely in the morning when their medication is on board may be a significant fall risk by evening when they are in an off period. Off periods can look like intoxication, shuffling, freezing, difficulty initiating movement, and an uninformed staff member may misinterpret what they see. Educating all staff who interact with Parkinson's patients, including nursing assistants, transport staff, and overnight personnel, is a system-level nursing leadership opportunity. Parkinson's disease is a caregiver's disease. That phrase, while perhaps provocative, captures a clinical truth. The non-motor symptoms, psychosis, dementia, impulse control disorders, autonomic dysfunction, sleep disruption, and are often harder on the person living with the patient than on the patient themselves. Among caregivers for people with neurological conditions, a category that includes Parkinson's, the rates of psychological distress are significantly higher than for caregivers of people with other chronic diseases because the duration of caregiving is long, the disease is progressive, and the non-motor symptoms, particularly psychosis, behavioral changes, and dementia, are profoundly disorienting and isolating. Research shows that 40 to 70% of Parkinson's caregivers experience clinical depression, and 70% report significant anxiety. Consider two archetypes of caregiver that clinicians encounter routinely. The first type, call her Sarah, presents her husband for his visit and answers the clinician's questions helpfully, accurately, and efficiently. She has recently lost weight. She has been quieter than usual. She makes an offhand comment about not getting out much. She does not volunteer that she is exhausted because she believes the appointment is for her husband, not for her. This is the subtle burnout presentation. It requires active, direct inquiry. Not, "How are you doing?" which invites a reflexive fine, but targeted questions. How many hours of sleep are you getting? When did you last spend time with a friend? How often are you helping with personal care? The second archetype, Mark, is highly competent and organized, tracks every medication dose, brings meticulous notes to every appointment, and reports that everything is under control. Mark is also sleeping 4 hours a night, has withdrawn from every social activity he used to enjoy, and has not told anyone because admitting struggle would feel like failure. The framing of support matters for resistant caregivers like Mark. Suggesting respite care as a break for you often fails because it implies the caregiver is not coping. Reframing it as a social opportunity for your wife to meet new people and stay engaged, which it genuinely is, shifts the calculus. Peer support is often more persuasive than professional recommendations. Connecting a resistant caregiver with an experienced peer who has navigated the same challenges can open doors that clinical advice cannot. The Parkinson's Foundation, the Davis-Finney Foundation, and American Parkinson's Disease Association all provide helplines, caregiver guides, and online communities. Knowing these resources and making warm referrals is the difference between a resource that gets used and one that gets filed away. Advanced Parkinson's disease is characterized by a constellation of challenges that go well beyond what levodopa can address. Motor symptoms, severe freezing, frequent falls, significant bradykinesia, are compounded by non-motor symptoms that become increasingly prominent and debilitating: dysphagia, drooling, orthostatic hypotension, urinary dysfunction, hallucinations, dementia, and depression. In nursing home residents with advanced Parkinson's, one study documented an average of 13 non-motor symptoms per resident that are usually underreported. Dysphagia in advanced Parkinson's is a life-threatening problem. Aspiration pneumonia is one of the most common causes of death in Parkinson's disease, and it is often preceded by months of progressive swallowing difficulty that was not adequately recognized or addressed. Modified barium swallow studies provide objective data on aspiration risk and inform speech-language pathology recommendations about texture modification and swallowing strategies. Nutrition in advanced Parkinson's requires flexibility and individualization. High-calorie, high-protein intake is important to maintain weight, but dysphagia may necessitate pureeing or other texture modification. At the end of life, allowing patients to eat preferred foods, even when aspiration risk is elevated, is a legitimate, values-concordant choice that respects quality of life over longevity. Palliative care should not be introduced at the end of life, it should be introduced at or near the time of diagnosis. This is not semantics. Early palliative care involvement means that goals of care conversations happen when the patient has full capacity, Before a crisis forces the discussion under pressure. It means advanced care planning documents are in place and reflect considered choices. It means the family understands the disease trajectory before they are in the middle of it. Tools like acpdecisions.org, 5 Wishes, and Go Wish provide structured frameworks for these conversations, and they work best outside the hospital, at a routine clinic visit, during a family meeting, or even at home through a palliative care home visit program. Hospice eligibility in Parkinson's is chronically underutilized because of the persistent myth that Parkinson's is not a terminal illness. It is. Patients and families deserve access to the comfort-focused support that palliative care and hospice provide. We have covered an enormous amount of clinical ground. Now let's bring it to life through the lens of real patient trajectories, because the textbook version of Parkinson's disease and the lived clinical version are not always the same thing. Cases anchor knowledge in a way that bullet points cannot, and they reveal the decision-making complexity that guidelines alone cannot capture. Consider Anthony, a 42-year-old who presents with subtle dexterity changes and reduced left arm swing. He had cervical spine surgery 2 years ago and initially attributed his symptoms to that. His diagnosis arrives at a stage when his symptoms are real but not yet function-limiting enough for levodopa. He begins with a MAOB inhibitor, starts cardiovascular exercise, and sees a speech therapist for baseline assessment. Within a year, anxiety and insomnia emerge, common in young-onset PD, where the psychosocial weight of a progressive neurological diagnosis in the middle of a career is enormous. He needs psychiatric referral, frequent nursing check-ins, sometimes 3 calls per week, and the specific clinical question of whether to disclose his diagnosis at work. ADA, accommodations, and intermittent FMLA allow him to attend therapy appointments without jeopardizing his employment. Now consider Michael, diagnosed at 63, who 8 years into his disease now requires a walker, falls 2 to 3 times per week, and has developed compulsive spending, which his family initially assumed was just personality, but which the clinical team recognizes as dopamine agonist-induced impulse control disorders. His speech has deteriorated to the point that his voice therapy referral is no longer aspirational but urgent. His fall prevention assessment identifies that he refuses to use the rollator because of how it looks, and the clinical solution is walking poles, functionally equivalent, aesthetically acceptable to him. 5 years after that, Michael's disease has advanced to include severe freezing, psychosis with visual hallucinations, orthostatic hypotension with near syncope, dysphagia, weight loss, and excessive drooling. His wife is physically and emotionally depleted. The clinical team's role now encompasses not just Michael's symptom management, but caregiver health assessment, advanced care planning facilitation, dysphagia evaluation with modified barium swallow, and palliative care consultation. These trajectories remind us that Parkinson's disease is not one disease. It is a different disease in every person at every stage. These 6 priorities are the distillation of everything we have covered today. Make the greatest difference in Parkinson's outcomes. Medication timing cannot be approximated. 3 times a day is not an instruction. It is a starting point for a conversation about when in the day this patient is awake, when they eat, when they are most active, and when they most need to be functional. The medication schedule for a patient who wakes at 6 a.m. for a 7 a.m. exercise class is entirely different from the schedule for a patient who sleeps until 9 a.m. and has their main social engagement in the afternoon. And in the hospital, the home schedule is not negotiable. It is the clinical target. A patient who takes their carbidopa-levodopa at a certain time at home should receive it at those same times in the hospital. Non-motor symptom screening must be proactive and specific. Constipation, mood, sleep, cognition, hallucinations, impulse control. Let me close with what I hope you will carry out of this room and into your clinical practice, not as 5 disconnected facts, but as a coherent philosophy of Parkinson's care. Parkinson's disease is a multi-system progressive disorder. The medication that worked beautifully 2 years ago may be insufficient today. The caregiver who was coping 6 months ago may be in crisis now. The symptom that seemed stable last visit may have quietly crossed a threshold that matters. Our assessments must be continuous, our plans must evolve, and our relationships with patients and families must be durable enough to hold difficult conversations when they are needed. Medication timing is patient safety. Caregiver support is patient care. Thank you. I hope what we have covered today gives you not just information, but the confidence to recognize, to educate, to advocate, and to lead.